All right, so we have another panel. In this case, is or a joint talk. It's about the introduction of our new data partners for phase 2. So as of tomorrow, we have several new data partners, and presenting today will be the Los Angeles County Department of Health Services, San Mateo Health System, Cedars-Sinai Medical Center, and Intermountain Healthcare, which will be done remotely by Adam Wilcox. So let me ask the new data partners to come up to the table and get started with their presentations. So first will be Anish from Los Angeles County. Yeah, is that the order? Or you can do the
San
order.
Mateo's going
San
first.
Mateo going first, then, so Laura Sheets, thank you.
Good morning. I'm happy to be here and joined by Dr. Spencer Suhu from Cedars-Sinai, Anish Mahajan from LA, and Adam Wilcox, who's joining us on the phone from Intermountain. I am the Business Intelligence Manager for San Mateo County Health System. And as soon as I figure this out, there we go. San Mateo is a medium-sized county, 755,000 residents. We have a low unemployment rate, as is true of most of the San Francisco Bay Area. And what people don't normally realize is that we have a very diverse population. We have places like Hillsborough and Atherton. We certainly have some of the high-tech money. Hillsborough and Atherton normally show up on the list of the 10 richest towns per capita in the U.S. However, those are not our patients. We serve coastal farming communities, a lot of migrant farm workers. We have people who are undocumented. And then we have East Palo Alto, not to be confused with Palo Alto. It is literally on the other side of the tracks. And it's a place that is very impoverished. Its crime rate is about 10 times the average for San Mateo County as a whole. That describes our population that we treat much better. 7.5% of the population is under the federal poverty level, and 46% of the households regularly speak a language other than English at home. That's primarily Spanish. We also have Tagalog and both Mandarin and Cantonese speakers. And in addition, we have the largest Tongan community in the U.S. Residing with us. San Mateo, for those of you who don't know, is between San Francisco and San Jose. This shows you where a lot of our medical clinics are. We have 3 mobile vans, we have a dental van, and we're starting with some telehealth as well, because we have a lot of remote places in unincorporated parts of the county where some of the places you can't even get a cell phone reception. So for the health system itself, we have 11 divisions. I won't go through all of them, but we'll call out 2 of them that are not normally part of a health system. One of those is aging and adult services. The other one is environmental health. So that really has added quite a bit to our data sets. The San Mateo Medical Center is the largest of the divisions, and it's the one where most of the data that we are contributing to this research effort will come from. We treat about 70 to 75,000 people annually. We have an acute care hospital. We have a lot of long-term care, an emergency department, a psychiatric inpatient, primary care clinics, specialty care clinics, and we do some specialty care. A lot of that we farm out to our very distinguished neighbors, such as Stanford. Some of them go up to UCSF, but we take advantage of the expertise that we have in the area. And with dental services, this year, it started off very small. At this point, we're up to about 28 to 30,000 visits that we're expecting this year. As I said, we have a small hospital. There's about 3,800 discharges per year. We have a psychiatric inpatient unit and long-term care. For our outpatient volume, we have about 300,000 visits per year. And then with our emergency department, we have about 40,000 visits per year. I wish I could say that we had a single electronic health record that served the whole health system. If anybody has found such an animal, I would love to hear about it. We have eClinical Works for the outpatient services. We use PISIS Pulse Check for emergency services, and we use what used to be the Siemens products. Siemens was purchased by Cerner, so we have those products. And within the medical center, all of those are combined into a single data warehouse. For our population, we have a few more women than men. This is at the medical center itself, 52-48. And when you look at our population, it's generally 60 and under. Obviously, once people hit 65 and have Medicare, they have a lot more resources available to them. In terms of chronic diseases, it's probably what you would expect. Hypertension, hyperlipidemia, obesity, type 2 diabetes, depression. These aren't a surprise to any of you, but that's what we are generally seeing. So our second largest division is behavioral health and recovery services, and they provide both mental health and substance abuse treatment to about 20,000 people a year. One of the things that we're very proud of is that we have a lot of co-location of mental health and primary care services. We have psychiatrists that do a lot of consultations with the primary care docs. It's been a big focus of our health system. So we have the inpatient ward in the hospital. We have a mental health rehab facility. We have residential treatment, day treatment on the mental health side. That's generally for child and youth. On substance abuse side, that's more for adults. A lot of outpatient services, especially in co-located clinics, school-based services, and we like to do a lot of outreach and education as well. Aging in adults serves about 15,000 clients per year. They do a lot of in-home support services. They support Meals on Wheels, adult protective services. They are the conservator for adult conserved clients as well. Family health services, the biggest program that they have is the Women, Infants, Children Supplemental Nutrition Program. And they provide a lot of support for teenage moms and Medi-Cal covered mothers and children through age 5. That's probably one of the largest populations that they support. They do a lot of field nursing, case management, home visits, and support for disabled children and youth through the age of 21. As I said, we have a lot of different medical records, and we have case management systems, and we are in the middle of an initiative to implement an enterprise master person index. It's revealed a lot of really interesting information to us, especially the overlap among the different divisions of who's being seen where. And this is the first step, and actually we found out that our data quality is better than we expected. Next on our list, we're going to start this probably in January or February, is a subscription to a health information exchange. And we're expecting to do this in concert with the health plan of San Mateo, which is the primary Medi-Cal, head of the Medi-Cal contract for San Mateo County. And much of the reason that we are doing this is so that we can have a longitudinal clinical record at the point of service for our providers, so they can see if the person is being seen in behavioral health and has psychiatric meds. You know, where else are they getting in-home support services? Is it a mom who needs some support with parenting classes, something like that? We also want to take advantage of the clinical data repository created in by the HIE, bring that back, combine it with the financial data. Huge for us to do population management. Obviously, we have to get into the implementation of OMOP, and we are actively planning for that. And following that, we're going to be incorporating data from the remaining health systems. So I've kind of sped through this. Our plan is to leave questions till the end. And here's my contact information. So thank you very much. Next will be Spencer Suhu from Cedars-Sinai.
Hello. Let's see. Sure. Okay, I see it. Oh, here we go. Okay, great. Thanks. So I'm with Cedars-Sinai Medical Center. This is sort of gives you an idea of where we're located. We are in the West LA, Beverly Hills, Los Angeles area. So depending on which building you're in, you can be in one of 3 different cities, which causes some interesting challenges if you're the facilities planner, because like we had one building where the cube walls were a certain level, and then walk across the other side of the building and they're a different level. But so anyways, we were established in 1902, and it's a level 1, have 866 beds, level 1 trauma center. This gives you an idea of the service area that we cover. So on an average, we're a pretty busy place. We've got 233 emergency department patients. You can just go through the list, but there are, so I just heard today the census was 822 patients, so it fluctuates a lot. This gives you an idea of our demographics. So we're an Epic shop. We went live on Epic in 2010. And we've been rolling it out gradually. We didn't try the big bang approach, so we've just sort of, we're pulling the Band-Aid off 1 millimeter at a time. But this gives you an idea of the statistics. We've got over 300,000 active patients, about 2 million distinct patients in Epic. This gives you a breakdown of our demographics. So commercial insurance, 39%, Medi-Cal, 11%, Medicare, 46%. This gives you an idea of the age distribution, female and male in total. So the slides didn't come out very well in terms of the legend. So this is 45 to 54 and then 55 to 65. And then this is the racial mix. So largely white. Things that we've done today in Epic, we've basically, the core product was implemented in 2014, and then, like I said, we've been rolling it out to other areas. So we've just we're going live with the oncology piece for Beacon for our ambulatory clinics next month. We're rolling it out to a lot of medical offices. Some of the things that we've been focused on that are really fun have been like the infusion pump integration with bedside monitoring. So we've our CIO made a concerted effort to get us to the HIMSS EMR adoption level stage 7, which we made in February last year. Areas of focus. So we've picked some areas of focus. Cardiology is a big area, neurosciences, oncology, and regenerative medicine. And so we've got a pretty energetic CIO, and he's been really pushing innovation. So 2 of the things that are really cool have been the focus on patient wearable devices and medication alerts. So this gives you, in April, we rolled out an addition to our patient portal, MyChart, called MyCSLink, and we allowed patients to register their wearable devices. So we've got Apple, Fitbit, and Whitings. So this sort of shows the level. So we started off, so right now we've got about 600 people who are enrolled in it, or who self-registered, and that gives you the breakdown of the types of devices. And this gives you an idea of some of the data that you can collect. So these are box charts. So this gives you steps, pulse, weight, glucometer inputs. And so we're collecting this data. people are starting to take a look at it and trying to figure out what they can do with it, but the data is being collected, and we expect that the adoption rate is going to increase. So the other thing that was really cool was the medication alerts. So there's the pop-up alert that happens if you got a change in medication based on different criteria. So this shows a 31% difference, decrease in the prescription of a medication based on the pop-up alerts. And so some of our statisticians did some projections and said, okay, so if we had a 31% decrease in that medication, here's what the potential impact was. So basically they predicted that we reduced 22 fall-related injuries in 1 year, reduced 6 ED visits, 3 hospitalizations, and possibly 2 deaths. So that's some of the cool stuff that you can do once you get all the data collected into one big system. So I'll stop there, and we'll pick up with questions later. Thank you.
Good morning, everybody. So my name is Anish Mahajan from LA County Department of Health Services. It's really a pleasure for LA County to become a partner here in pSCANNER. I'm going to just take you through a few slides just describing who we are and what kind of patients we take care of. So we run the LA County county-run health facilities. Our governing body is the County Board of Supervisors. We have 4 hospitals, 3 of which were academically affiliated, LAC, USC Medical Center with USC Medical School, and then Harbor, UCLA, and all of you medical centers with UCLA. So we have a lot of, both voluntary and county investigators very interested in getting access to better data, and certainly are excited about what we can do here with pSCANNER. Our hospitals are large. LAC, USC, and Harbor, UCLA are level 1 trauma centers. All of you is a pretty large community hospital. Rancho Los Amigos, see if I can figure out the pointer. Rancho Los Amigos is a national rehabilitation hospital, so really taking care of people with spinal cord injuries and other kinds of neurological and neurodegenerative disorders. We have some large ambulatory facilities. Everything from sort of primary care to same-day surgery, and then a number of health centers with specialty in primary care throughout LA County, a number of just primary health centers. We also are going to run the jail health services. We run the juvenile court health services and the EMS agency. So it's a very large system, full kind of clinical care, everything from primary care all the way through highly specialized services like a burn unit, and other kinds of surgical specialties. So, as I mentioned, it's a very it's a large system, lots of effort and lots of folks, lots of money is expended. We don't quite know how well we expend that money. There's a lot of work we need to do to ensure that we're getting really good, effective care with the level of investment that the county is making, that taxpayers are making in our system. We take care of about 600,000 unique individuals each year, translates to millions of outpatient visits, over almost 300,000 ER visits, about 70,000 inpatient discharges every year. Something since over the last 2 or 3 years with the Affordable Care Act, we've really tried to become an integrated healthcare delivery system. And so, as you know, with Medicaid or Medi-Cal expansion here in California, it's mostly managed care. And so we're working hard to impanel patients to primary care medical homes. And so we have about 450,000 unique lives impaneled to primary care in our facilities. About 300,000 of those are actually Medi-Cal managed care members. Another 150,000 are residually uninsured people, likely to be undocumented people, that we are treating in exactly the same way that we treat our managed care members, in a sort of PCMH style care delivery model. These are just a few basic demographics, a snapshot really probably from a year or 2 ago, gender, and you can see the age, much like our colleagues in San Mateo. We take care of a population younger than 65 generally. As people get Medicare, they generally go elsewhere. These are the racial and ethnic demographics, as you can see, heavily Hispanic and African American. Just wanted to say a couple words about sort of our approach to data. that we're working on. We have Cerner electronic health record. We're rolling out, and we've done 75% of our facilities, soon to be 100% by March. We'll all be on a single instance of our Cerner install. We have obviously other sources of data, as everybody else does. We've got our managed care systems that grab our eligibility from the plans, our out-of-network claims, and other kinds of PBM data. Lots of financial accounting data, our outpatient medication system, our provider database called Cactus. We've also gone very significantly in the direction of standing up an e-consult or e-referral style platform. Many of you probably have heard of this, seen it in San Francisco. That is the way that we have patients access new appointments in specialty care through an e-consult platform. We've made an investment in an enterprise data repository. We've installed IBM InfoSphere for our EMPI management. We've had that now for about a year and a half. We're using Oracle's Healthcare Data Warehouse Foundation as our enterprise data warehouse. And so in our first phase, which we completed about 5 months ago, we sort of put we put a lot of utilization data, a lot of health plan data, and a lot of patient accounting data to solve some of our finance groups reporting problems. Our phase 2 is ongoing at the moment. We're harvesting as much clinical data as we can from our Cerner install into our data warehouse to sort of meet clinical and operational metric requirements and to build data marts that mostly our clinicians and other kinds of staff that manage our managed care organization can use to help our delivery system. The goal is ultimately to try to make our data, bring it as far to the front line as we can. As you all know, in this room, you really can't do this if you don't have proper data governance. In a system of our size, with the number of people that touch data, this is a big challenge and something that we have to do to make the data useful. And we're also really trying to figure out how to prioritize through a business intelligence approach, what we should build, how should we use our data. And I think, hopefully these things will help us be a good partner with you guys in pSCANNER. I'm going to finish with, in LA County, what I've described so far as the Department of Health Services. The County Board of Supervisors recently voted to create a health agency in LA County, which essentially means that we will now have an agency model with each of the health-related departments reporting up to the agency. I raise this because there's lots of incredibly good data in public health and in mental health. We are the physical health portion of the county. Our hope is to really bring all of this data together in a single, integrated data system with a single data warehouse and really try to take care of the whole person rather than partition the person between their mental health and their physical health and their substance abuse problems. So I'll stop there. Thanks.
Hi, so this is Adam Wilcox. I want to first get confirmation that people can hear me.
Yes.
Yes.
Okay, great. So I'll start with an apology that I can't be there in person. I'm getting some feedback, and I don't know. If it's fine with you, I'll just keep going through the feedback.
Yes.
We can hear you fine.
Okay. If you can hear me, I'll just keep going. So, Adam Wilcox, I'm here at Intermountain Healthcare. Obviously, I'm not there in San Diego. I wish I were, and I apologize first for not being there. I recognize also that I am the closest, I'm in between you and lunch at this point, so I want to move rather quickly through this. So, if someone could advance to the next slide, which should show a mountainous region, which represents Intermountain Healthcare's area. So, Intermountain Healthcare, we are a large integrated delivery network that serves basically the whole state of Utah and a little bit of southern Idaho. I like this map because it shows the topography, which is why we're intermountain, because there's a lot of mountains nearby. There's a lot of mountains throughout our region. In terms of details, next slide, about what that means. So we have 23 hospitals in our integrated delivery network. Our patient population is about 2.1 million. So in terms of the patients that we have some data on, about 133,000 inpatient visits annually, almost 500,000 emergency visits, about 40,000 inpatient surgeries, about over 30,000 births. That's actually one of the most common, in our area, one of the most common procedures that we have is births. A young population and a high birth rate. In terms of our physicians and clinics, we have over 1,400 multi-specialty physicians and caregivers and nearly 200 clinics, which are providing over 100,000 ambulatory surgeries. And we have a health insurance plan which covers about 750,000 members. The way to think about this is the following. Intermountain Healthcare, in terms of inpatient care, provides a little over half of the inpatient care of the region, which is primarily the state of Utah. We cover about a third of the lives in the area, and then we provide about 20 to 25, maybe going up to 30 in some cases, percent of the ambulatory care. And there's a sizable population of people who receive pretty much all of their inpatient, outpatient care from Intermountain facilities, and also are within our health plan, which for a long time has been an interesting group to study because we have that much data on them. So going to the last slide, I want to talk about why we're excited to participate in pSCANNER and what we feel that we bring that may be interesting. First of all, the benefits to us is that we get to participate with the PCORI project. And so I was very grateful when Lucilla talked to me initially about the opportunity for Intermountain to be involved in this, because I wanted to participate. We're actually also participating in another one out of Mayo Clinic, and I'll get to that one a little bit on that later. We see a benefit of the analytic data models and tools that, we need to move this data into these analytic data models. And in doing so, there's an opportunity to leverage various tools that can sit on top of that data and make it more useful in different ways. And there's a nice opportunity for us to participate in this PCORI vision of kind of learning health system and patient-centered around patient-centered outcomes. I've been personally working a lot with PCORI for a while, both at first as a reviewer and applications to it, and now as a member of the methodology committee. And I feel I'm very committed to the mission of PCORI and grateful to participate in PCORI in this way. The contributions, there's three major contributions that I think that we bring as Intermountain participating in this group, and I should have probably switch the first two. So first, we're a large integrated delivery network where we cover a large, relative to California, I recognize it's not a large population, but in terms of the coverage of the area, a large proportion of the population and do have a large group that we cover fully. So that data from that integrated delivery system can be useful. Also, Intermountain Healthcare has long experience in informatics, both in design of electronic medical record systems, in the use of decision support, but also in leveraging data and analytics for that. And then finally, there's the opportunity here for a sustainability study, and I want to spend the rest of the time kind of going over that. So first, these phase 2 grants are really designed around sustainability. In fact, as we all know, the third year is half funded for that purpose. So there's money in these phases to build up an initial infrastructure and to extract and model data from different institutions. But that's not expected to be going forever. I don't know that PCORI plans, and every indication I'm seeing from that organization is they're not planning to keep funding consistently more and more organizations to participate in this and paying them for that participation. They're definitely not planning on paying for building up of the more initial infrastructures. So the question needs to change from how much money do we need to participate in this project to how much do we really want to participate. And one thing to think about is that cost is actually separate from commitment. That sounds pretty bold, but let me explain it. Our biggest cost for participation in this project is modeling data into an analytic data structure, but that's something we already wanted to do. For example, we aren't being paid to participate in OMOS and to model our data into that form. There's some extraction for this project into disease-specific areas, but if we aren't already interested in those areas and want to be extracting data from those areas, we probably shouldn't be participating anyway. And I'm speaking just in terms of my organization in this case. What's the biggest risk that we have of participation? First of all, is sharing data and data loss. And I recognize that the way that the CoreNet is organized and pSCANNER is organized, that is minimized. But any organization that's participating in an initiative that has some form of sharing data or even distributing queries for results of data is quickly facing concerns and at least perceived risks of greater costs from data loss in terms of fines and remediations than you could actually get from the project. So money in that case doesn't really buy a commitment. If Intermountain Healthcare was concerned enough about data loss, they wouldn't say to me, well, we're really worried about this and we don't want to participate, but we're going to because they gave us some money. So what do we gain as an organization participating in it? So as I mentioned, CoreNet is an important initiative, and we believe that it's going to help redefine how patient-centered research is done, and it's the type of project that we want to be an early adopter, not a laggard. And pSCANNER is a perfect fit, not just because of the regional nature of pSCANNER, but also because the opportunity for collaboration with the organizations and the research and informatics leaders in the project. So with that background, I want to tell a little story. So a few months ago, before the Phase 2 awards were announced, I had a conversation with Lucilla about budget. And in short, the question was, what can we do to increase efficiency of pSCANNER, particularly Intermountain's participation? So I made a proposal to her based on what I've told you about our interest, and that it wasn't about cost, it was that we wanted to participate. That is asking, can we participate as a sustainability study? We won't ask for money for participation in the network, but we can participate. And then obviously, if there's studies identified, we would want to get funding related to those studies as the CoreNet is supposed to work. But the core participation, we would foot the bill ourselves. And that would create an opportunity to test what the real benefits of participation are. So what does that mean to all of you? I know what it means to me, but in terms of all the other participants. First, we do have an interesting sustainability study from this. Second, you can say that at least one organization in pSCANNER is willing to participate independent of funding, and you don't have to be that institution. But this can be helpful if you talk to other organizations about what participation really looks like. Third, we hope that we can really identify what is needed going forward to sustain the network. Of note, as I mentioned, we did get funded on a second Phase 2 proposal through Mayo Clinic, so there now becomes a little less risk for our participation than was first imagined because some of this work we're already going to be doing, but we're still participating here without standard funding. So I think this summarizes the most important part about our status as a new member of pSCANNER. We're a large integrated delivery network in the geographic center of the network. We have a lot of experience in informatics and using data, and we're participating in the sustainability study, and we're really glad to be part of this group. Thanks.
We wanted, I guess, our story is that our CEO heard about pSCANNER and said, why aren't we part of this? And so he got me started into, so we self-funded part of some of the infrastructure, some of the other infrastructure we're able to leverage because under the CTSA with UCLA CTSA, we had implemented I2B2 and Shrine. Mm-hmm. So we're able to leverage a lot of that infrastructure.
We haven't started yet, but we hope to.
And Adam?
So we've started already with the conversion to OMOP, and we've done some conversions we've probably done most of our conversion already to the CoreNet common data model, but we want to move it to OMOP and then do the transformations directly to the common data model because we think long term that's going to be more beneficial. But we've already done initial passes where we've done probably 70% of the data, both in OMOP and both in the CoreNet CDN.
Looks good.
I'm just curious about how you guys see this kind of project fitting into the business priorities of your organization and where this might be synergized with things that you feel is important. And I'm actually particularly interested in things that came up with the relationship to environmental and mobile, because it seems like those two things fit together fairly well and are not data domains that we've contemplated extensively. But the first question probably first is, where is this on the priority list?
Well, we have a fairly vigorous data governance model in place, and so we wouldn't have signed up if we didn't feel like there was a lot of going in the same direction. We try to be very patient interest driven. So I feel like it's like we're very much in line with it.
Kathy, or
Okay, so at Cedars-Sinai, our senior leadership's very, very motivated. I mean, they would love to do what they can to advance the delivery of healthcare, and so they view these things like this as a perfect opportunity to do that.
So I'll speak for LA County. For us, our number one priority as it relates to data and IT is improving the delivery of care for our patients. And so this supports that, but it doesn't directly, overlap with that. And so I would say that, that doesn't mean that this isn't important to us. And we have an education mission, and we have affiliations with the USC and UCLA. It's very important that the kinds of patients that we serve, low-income people, undocumented people, people on Medicaid, and people who are uninsured, be a part of these kinds of data sets. And so that is probably the primary driver from our senior leadership and from our investigators for wanting to be a part of this. And so we're going to do our very best to do that. I think one thing Danielle and I have talked about is that, we get lots of requests like this, and Doug is building something very, very excellent locally in LA County, similar to this. And what we're looking to do is try to figure out how can we make an investment in infrastructure, process, and architecture that meets local health information exchange for research needs, as well as the national, like PCORI, and that's what we're trying to figure out.
one more question.
Yeah, I'm glad to hear that you all are very patient-driven. I'm wondering if what your experience is in having patients involved in the kinds of issues that you deal with in terms of data governance, research infrastructure, what participation have they had, and what are your ideas for how you could engage your patient populations in those issues?
I don't think we've really tackled that yet. I mean, we haven't really, I'll be honest with you, we haven't really addressed that yet at all.
Yeah, no, I think you raise a very important issue that many people, even in our organization, raise as an issue. We haven't figured it out either. How do you do that? And we would look to learn from other participants here who have succeeded in that.
And I would say that for us in behavioral health, it's very patient-driven. In fact, the mental health, it's now the Behavioral Health Board, drives a lot of the initiatives, and there's a lot of outreach. So I think that the medical side can learn a lot from that. We're probably certainly not as advanced on the medical side as we are in behavioral health.
And this is Adam, and I would say that we're probably a step away from that. We've done projects, especially in mental health integration, where it has involved a lot of data coming from patients and much more of the patient perspective. Right now, we're probably in the stage where we're looking at population health, and there are some that are more involved in that who've definitely discovered the importance of the patient engagement, and we've created committees around patient engagement. I wouldn't call us a leader in this area, but I think that we will be a very strong adopter. And once we learn the right way to do that, and I think that's an opportunity for us in this participation.
Great. So I would also like to thank the pSCANNER members who approached these teams in order for them to participate, and that those were Mike Hogarth for San Mateo, Doug Bell for Cedars-Sinai, and Daniela for LA County, and Lisa with the Intermountain Healthcare. So I want to thank you all. As you saw, it was very diverse systems, a lot to contribute in different areas, and I'm pretty sure will be a very intense 6 months to get up to speed with all the OMOP and PCORNet CDM. So